Thank you so much, Peter. To be called a hero by one of my heroes is an honor indeed. A dark cloud hangs over IHI's home base, Boston, this year. It's the cloud of the Boston Red Sox. This is very painful for us, especially painful for Maureen Bisignano. She's my closest colleague and the brilliant EVP and COO of our organization. Maureen is as avid a Red Sox fan as she is a golfer, and that is saying a lot if you know about Maureen in golf. Just this fall, she phoned me after a weekend round of golf to tell me a terrible story. She had been on the third tee when her golf partner, Fred, dropped dead of a heart attack. I said, Maureen, that must have been so hard for you. She said, you have no idea, Don, how hard it was. It took forever. Hit the ball, drag Fred, hit the ball. So Maureen was a real mess when, again, the Red Sox, her beloved team, got knocked out of the semifinal round, the American League Championship Series, by our arch rivals, the New York Yankees, Satan's team. If you're not from the United States, and over 1,000 of you are not from the United States, let me explain. The Boston Red Sox suffer from a disease, which we call the curse of the Bambino. The Bambino is Babe Ruth. That was his nickname. He was probably the greatest baseball player of all time. Babe Ruth began his professional career with the Boston Red Sox, but in 1920, in search of filthy lucre, the owner of the Red Sox sold the Babe to the New York Yankees, Satan's team. When Babe was on board, the Red Sox had won the baseball championship, which we Americans humbly call the World Series, in 1918. But they never won it again. Meanwhile, the Yankees have won the World Series 26 times. We in Boston know that the gods have engineered this century of failure because of the treacherous trade, so they call it the curse of the Bambino. Now, the Red Sox have fixed this problem many, many times, never by winning the World Series, but by firing people. It's a famous moment in the 1986 World Series, the Red Sox versus the New York Mets, that's Satan's other team. It's seared in my son's memory, and don't even think of mentioning it to Maureen. Our first baseman, Bill Buckner, muffed an easy ground ball, and the Mets went on to beat us. We fired Buckner. This year, in the seventh and final game of the American League playoffs, the Red Sox manager, Grady Little, shown here, left our worn-out star pitcher, Pedro Martinez, in for one inning too long, and that let the Yankees come back from way behind to beat us. Grady Little is now the former manager of the Red Sox, and that'll fix it. This all leads to a common bet in the Boston area. People bet on which will happen first, X or the Red Sox winning the World Series, for any X. Graduate students, thesis supervisors ask them if they'll finish their PhD thesis before the Red Sox win the World Series. Their mothers ask them if they'll get married before the Red Sox win the World Series. I ask my kids if they'll clean their rooms before the Red Sox win the World Series. I promise I will empty my email inbox before the Red Sox win the World Series. So in that spirit, I want to ask you a question. What do you think is going to happen first? The Red Sox winning the World Series or the health care we ought to have? Being a healthcare improvement fan and a Boston Red Sox fan have something in common. Playoffs, but no series. Until recently, I actually would have bet on the Red Sox. Now I'm not so sure. It's been a very good year for the quality movement. I think a real turning point actually came a little more than a year ago when Sister Mary Jean Ryan and her colleagues at SSM Healthcare earned and won the Malcolm Baldrige National Quality Award. They met world-class quality standards with the best assessment criteria we have on the same playing field as other industries. And now we have the news just out that two more places have won the Baldrige Award, Baptist Hospital in Pensacola and St. Luke's in Kansas City. The IHI had a good year. I'm very proud of the people I get to work with in my organization and just want to take a minute or two of your time to show you some of them and laud them. We launched our new Impact Network, as Vin told you. It's called the Association for Change. That's what I call it. Impact has 111 member organizations. More are joining every single week. You can spot an Impact member here by the button they're wearing. IHI staff Carol Beasley and Sarah Jackson, in a stellar crew of our directors, lead Impact. Our Vice President, Carol Harridan, orchestrates our innovation projects and collaboratives in patient safety and intensive care settings and flow throughout the system. Our Vice President, Pat Rutherford, heads our work on office practice redesign, and she now runs a new and exciting project sponsored by the Robert Wood Johnson Foundation called Transforming Care at the Bedside. That's part of IHI's growing focus on helping the nursing profession, something we just have to tackle as a top priority in American healthcare. Our Senior Vice President, Penny Carver, has been taking us into 21st century use of the web. We are about to merge our two websites, qualityhealthcare.org and IHI.org, into a single resource that'll have everything that both has. You're going to see there this year more distance learning opportunities and web-based collaborative improvement projects. Our communications director is Jonathan Small, who produced that terrific annual report that's in your tote bag or on your chair. And our publications team with Frank Davidoff, Jane Rosner, and Val Weber this year helped our faculty write and publish over 25 peer-reviewed articles this year. Tom Nolan and Andrea Capsonell helped me lead the Pursuing Perfection project, also funded by the Johnson Foundation, and it has begun to show very impressive gains in 13 sites, 7 in the US and 6 in Europe. You can read their composite storyboard, the mother of all storyboards, in the storyboard reception area. I encourage you to do that. Even more important than that, I really think now that we're starting to see in the United States an increasing number of organizations, still a few, but they're really there, that are finally really aiming for whole system change of the type Peter was talking about, what we've been waiting for, improvement as a core strategy. I'm thinking of places like, and people like Randy Linton and his colleagues at Luther Middleford, or John Toussaint and Scott Decker at ThedaCare, George Kerwin and Pete Knox at Bellin Health System in Wisconsin, Gary Kaplan at Virginia Mason, Sister Mary Jean and SSM everywhere, all of the Mayo Clinic sites, Leo Bordeaux at Columbia St. Mary's, Bill Corley, Community Hospitals of Indianapolis, and Doug Eby and his colleagues in the Alaska Native Medical System. That's just to name a few. We have a great professional education team making progress, led by Paul Batalden and Paul Greiner and David Stevens and David Leach, and I really think we're starting to see those important behemoths begin to move. We have a network of 13 academic medical centers working together. And the movement's absolutely global. Sweden, Norway, the UK, Netherlands, Australia, New Zealand, they're just a few of the bright spots. In the UK especially, the improvements are just soaring with the help of colleagues and friends of the IHI like Sir Liam Donaldson and Sir Brian Jarman, David Fillingham, Helen Bevan. John Oldham, our friend and associate, was knighted this year. He's now Sir John Oldham. He told me to just call him Sir because of what he's done to help improve primary care services in the UK. The IHI is now working with the World Health Organization and soon will expand our efforts into fighting AIDS in sub-Saharan Africa and other of the most resource-poor countries in the world. Federal agencies are doing exciting things. Medicare has bold new programs to encourage exceptional quality of care, led by Steve Jenks and Sean Tunis and Barbara Paul and Mike McMullen and others. Sam Shaker at the Bureau of Primary Care and HRSA is leading an amazing transformation of access and chronic care, and the Veterans Health Administration continues to lead on safety. I want to take one more quick detour to tell you about an opportunity that excites me in the IHI at the moment, thanks to the generosity of the children of George W. Merck. Under the leadership of Howard Hyatt and Bob Carter, we're now offering George W. Merck fellowships at the IHI. These will allow 4 people each year for the next 5 years to join us in Boston for the entire year. They will be usually mid-career people, targeted for senior positions in the organizations that nominate them. Those organizations have to nominate them, support them, and guarantee positions for them when they return as leaders of change in those settings. Our first 2 fellows are David Stevens from the AAMC and David Calkins from the Harvard Medical School. If you want to learn more about the George W. Merck Fellowships, just get on our website or track down David Stevens, who's here. Trying to keep up with this is daunting for the IHI, and I also want to mention to you that our IHI management team, rounded out here by Tom Novak and Joanne Healy, have been working with our staff this year on an enormous redesign of the IHI. Now, as part of that redesign, we decided that we're going to focus all of our energies. We're going to judge ourselves on what we are actually achieving on the IOM's 6 dimensions of improvement, which you will recall are safety, effectiveness, patient-centeredness, timeliness, efficiency, and equity. We're going to make IHI even more results-oriented than we have ever been before. Now, we have rephrased the IOM's aims just a tiny bit. These are the results we now are going to get, and we want to get them with you. No needless death, no needless pain, no helplessness, no unwanted waiting, and no waste. We want those results for all, for everyone. That's the sixth IOM dimension, equity. That's what this organization exists to accomplish. That is how we will measure our progress, and that is how we will measure your progress. This clarifies our priorities. We want to choose to work on what helps get that done, and we will turn down chances to work on things that don't. So with all of this, I'm bullish on improvement. It's a tight playoff series, but I think the quality team is pulling a little ahead, at least of the Red Sox. Maybe the curse of the chasm, the healthcare quality chasm, will fall before the curse of the Bambino does. The trick now, same as for the Red Sox, is to put it all together. This year, the stakes on that race, the race to put it all together, are going up for me. Pretty soon for me, what's been a spectator sport is going to be a participant sport, and I'm going to explain that in a minute. But first, I need to tell you a story. This is my favorite saying. It comes from Gandhi. You must be the change you wish to see in the world. My colleague, Manoj Jain from Tennessee, told me a story from this book by Gandhi's grandson that makes the point clearer. The story is about a 10-year-old boy named Anil. Anil had become obese, and he was showing signs of diabetes. His mother had tried to intervene, but she was at the end of her rope, and so she took Anil in 1938 to Gandhi, and she asked the great man to please ask Anil to stop eating sweets. No cakes, no pies, no candy. It could save his life. Gandhi refused. He said, I can't do that. You'll have to come back in 15 days. But why not, Gandhiji, the mother? And he said, come back in 15 days. So she left, disappointed with Anil. She came back, as Gandhi had asked, with Anil in 15 days, and then Gandhi sat with the boy quietly and talked quietly, and the boy arose smiling. Why couldn't you have done that 15 days ago, the mother asked Gandhi, and he said, because 15 days ago, I also was eating cakes and pies and candy. Now I have stopped, and so I could tell Anil that I won't start eating them again until the doctors say he can. And that's a rather interesting idea, I think, helping by joining. It's also a little bit scary. The problem we need to solve to meet the challenge Peter put to you is this. Despite the good news, no one seems yet to have put it all together for total quality of care. Like the Red Sox, real transformative change is still a bridesmaid, not a bride. It must be very hard to get there, to total quality. It must be requiring some different level of energy or insight or courage than we've been able to muster so far. But I think I have an idea about how we can do it, at least the next step, and that's what I want to talk with you about, and where the courage is. I propose this. If we're going to care enough to do it all, to win the series, really, really different care, we're going to have to change the way we see our patients' lives. This afternoon, you're going to hear patients talk about their stories. Can you listen to them not as movies out there, but as mirrors in here? We'll change when we look at the people we want to help and see ourselves. When we realize that their needs out there are our needs in here. When we realize that the white coat and the dark suit are disguises. I'm toying with this idea that the next big step, our next big step, is not just to serve the people, but to join them, as Gandhi joined Anil. I want you to take a risk with me. I've never tried this with 14,000 people or whatever it is before. Would you take a moment now quietly and ask yourself what health care you or someone you love might need between now and when the Red Sox win the World Series? You have the next 2 days at this forum to design exactly the care you want. That's going to take courage. I'm asking you to drop your guard, to be a patient, and I want you to understand what you need. I hereby declare that for the next 2 days, you have a right to demand the help you want, when you want it, and the way you want it. And I'm going to go first. Tomorrow afternoon, at the close of this conference, I must say, we're going to hear from one of the most unselfish human beings I've ever met, Paul Farmer. Paul is devoting his life to helping people much less fortunate than he is. Now, I'm going to help Paul out by being the balancing act. I'm going to start at the other end of the spectrum, complete selfishness, self-centeredness. This is all about me and my knee. This is my right knee. It's the one on your left, my right, which worries me. I was born with 2 knees. Now I have about 1.7 knees. It began when I was in medical school. I was playing soccer one day, and my right kneecap subluxed or dislocated for a second toward the outside of my knee, and then it flipped back into place. That hurts. When it happened again, I went to see a surgeon. He said that my knee mechanics weren't lined up right and I needed an operation. Now, I was a nerd in medical school. I know that's hard to believe. So I had read up on myself in advance, and I asked the surgeon if he thought an operation, which I believe was called the McRae procedure, I was trying to remember would be a good one. He said, fine. And so I had that procedure a few weeks later. Oh my goodness, I remember the pain when I woke up. It was so bad that for a minute I couldn't even feel the pain. It was like a big truck that was so close to my face that I couldn't even tell at first it was a truck, and then the truck hit me. For about 2 days, pain, absolutely nothing like a subluxing kneecap. It wasn't even on the same continent of pain. But I trusted medicine, and so I went through it with what I'd call writhing optimism. Since at least I thought my problem was over, and it sort of was over. My kneecap never again subluxed to the outside of my knee. A few weeks later, it subluxed to the inside of my knee. So I went back to see the surgeon. He was very apologetic. He said that he apparently had overcorrected the problem. I agreed politely. I asked him if he had ever seen that before. He said no, actually, because that was the first time he'd ever done that particular operation. Something he hadn't mentioned to me when it all started. Maybe I should have told you, he said. I agreed politely. Within a few years, by the way, when it was finally subjected to a randomized long-term follow-up study, the procedure I had for my kind of problem was thoroughly discredited. Its complication rate turned out to be well over 30%. So I went to another surgeon at a different hospital, community hospital actually, near where I grew up. The surgeon there was happy to help me. He did a very simple repair job, which went very well, except for 2 days of shaking chills and a temperature of 104 post-op. But at least my knee never subluxed again, and that was for 20 years. At age 45, I was playing basketball with my kids when my knee, the same one, my right, your left, suddenly gave way and exploded in pain. A bunch of tests followed, x-rays and CAT scans and MRIs, but no diagnosis. Everything looked okay. The local orthopedist said he couldn't see a thing, except I couldn't walk. So I was a little frustrated. I went to a sports medicine clinic in another city where I had seen actually some terrific improvement work, and I saw a specialist that I had admired. He agreed that the test didn't show anything, but he had a clinical suspicion that I'd torn a cartilage, and so he did arthroscopic surgery. No pain this time, by the way. He found a cartilage tear, and he trimmed it, and that did the trick so well that I increased my jogging, and 5 years later, in 1998, I ran the Boston Marathon for the first and the last time. My friend says that given my knee history, this shows that I have the courage of a lion and the brain of a gerbil. I agreed politely. It was my only marathon because during it I blew out my cartilage again. I ended up on the arthroscopy table a second time, my 4th knee operation, and I lost most of the damaged cartilage. Now, 8 years later, my knee has pretty much had it. If you could read this x-ray, you would see that the cushioning cartilage on the inside half of the joint is totally gone. I have in the poetry of the orthopedic surgical literature, bone on bone, which is a bad thing in a joint. It's supposed to be cartilage on cartilage. Bone wears down, cartilage doesn't. So I don't know when, but sometime, and I think it's pretty soon, I'm going to need a total knee replacement, maybe even to walk, but most certainly to do the things that I love to do outside, like hike and cross-country ski and climb. Frankly, I don't think I'm going to be able to hold out until the Red Sox win the World Series. But here's my problem. I'm scared. Actually, I'm really scared. That is not a rhetorical statement. It is a fact. I know that my future functioning is going to depend on taking advantage of an amazing technology, total knee replacement, but I also know much too much. I know much more than I want to know about what could go wrong. I told you that in the IHI, we're going to focus now on 5 goals for healthcare change in the world. No needless death, no needless pain, no helplessness, no unwanted weights, no waste. At a system level, these are a vision. At a personal level, that is for me and my knee, they're more than a vision, they're a need. So I had a meeting with my knee, and we decided to issue an RFP. It's a request for proposals, like a foundation does when it wants some research done, or a company when it has a contract to let. My knee and I want to get some bids. We'll set the specifications, and anyone who wants to bid might get the job. The specifications are the same as the IHI's vision, the no needless list. But since it's my own knee, or my 0.7 of a knee, I need to adapt the RFP with a little more detail. The RFP actually is written out, and it's in your tote bag. Specification number 1 is no needless deaths. My RFP says it this way: don't kill me. At first I wrote, please don't kill me. But then I decided to be a little more assertive. So what do you think? To prospective applicants, I'm warning you, I do not take this deliverable for granted. When I give you the contract on my knee, it will absolutely be a little bit like what the mafia also calls a contract on my life. You become 007, licensed to kill, me. You see, the minute I slip under your anesthetic and your knife, I will without any doubt be taking the greatest risk to my life, statistically, that I've ever taken. It will be greater by at least 1 order of magnitude, I think, maybe 2. I have climbed Mount Rainier, crevassed and glaciated with vicious weather 5 times. On those 5 climbs combined, I was running a risk of dying, if you take the historical data, less than 1/50th as great as I will take on your operating room. Every airplane flight I take will be 5,000 or 10,000 times less lethal than my flight through your operating room. Here is how you can kill me. Actually, there are too many ways to list them all, but some of the ways you can kill me follow. You can give me an infection during my surgery. You could mix up blood transfusions if I need blood. You could fail to prevent my pulmonary embolism. If I need a respirator for a while when I wake up, you can give me pneumonia. You can forget that I'm allergic to hazelnuts and might be to codeine. You can misplace a decimal point on my morphine order. You can place the endotracheal tube by mistake in my esophagus and not realize it until it's too late. Everything on this list, by the way, everything happens and can be prevented, not down to 0, but awfully close to 0, at least Mount Rainier close to 0. I'm asking you to make me as safe in your care as I am in my home. No, just make me as safe in your care as when I crossed the crevassed glaciers of Mount Rainier. I can give you some hints about how to do that. You can bring my surgical site infection rate as low as it is at LDS Hospital or at Baptist DeSoto. You can prevent deep vein thrombosis and ventilator-acquired pneumonia as completely as has been done at Dominican Santa Cruz and Baptist DeSoto. You could be as attentive to medication errors as at OSF, or you can use the VA's approach to preventing esophageal intubations. Do you know that in America, esophageal intubations in non-critical care intubations happen 8% of the time? Without my RFP, I'm going to be entering the lottery of safety that we now have in this country. 4 years ago, I sat in a room with 30 CEOs as they were shown their complication rates for, of all things, total knee and total hip replacements at their own hospitals. The rate of complications among those 30 hospitals ranged from 3% in the lowest hospital to 21% in the highest hospital. Now forget about the 21%. Even 3% doesn't feel that good to me, frankly. If I told you you were about to do something that stood 1 chance in 30 of hurting you really, really badly, would you do it? But beyond that, I have to tell you that as far as I know, no member of the public had access to that information at that time or since. In my RFP, I'm going to ask you to please tell me how you are doing, and if you don't tell me, then I'm going to have to assume that either you don't know or that maybe you have something to hide. I do not mean to be strident or rude, but I really don't think you have a right not to tell me your results and then expect me to give you my knee to work on. Actually, I've already tried that. That's sort of what happened with that very nice first orthopedic surgeon. He did an operation he'd never done before, and he couldn't possibly have known the chances that it would help me or hurt me beyond a wild guess. If that's what was going on, he should have told me. He was very nice, but he should have told me. You might kill me. And I want you to promise me that you know that. And I want you to promise me that you've done everything you possibly can to reduce that risk to its theoretic minimum. None of my children are married yet. I haven't met my first grandchild yet. My wife and I want to take a trip to Nunavut sometime. I want to hike in the Himalayas. And now that I think of it, I want to watch my son's faces, Ben and Dan's faces, when the Red Sox do win the World Series. And after that, I want to go to the party that Marine's going to have. And if you take that stuff away from me by killing me, I will be very, very upset with you. Specification number 2 in the RFP is no needless pain. Now, I have to explain this one to you in my own terms. It means, assuming you don't kill me, don't hurt me either. Now, that's a little unrealistic, of course, because I know surgery itself is a form of hurting. I accept that. I'm not asking for perfect. I'm asking for the least possible harm. That means I want you to know what's the least possible harm anywhere, and that's what you need to get from me. Specification number 2 actually has 3 subparts, which I call 2A, 2B, and 2C. 2A is this: don't do stuff to me that won't help me. I do have a track record on this. As it happens, I don't think that I ever needed surgery on my knee in the first place. I certainly didn't need the extensive, painful, and since discredited procedure that guy tried on me for his first time. The subluxation problem that I had was actually quite minimal. I actually think now that a brace and exercises would have been just as good. I think I fell into the trap that Jack Wenberg has been trying to point out to us for over 2 decades, that in healthcare, supply drives demand without regard to the quality of outcomes of care. Wenberg's work